Chers amis, chers collègues, prenez place. Bonsoir tout le monde. On est ravis de vous voir nombreux pour ce colloque extraordinaire avec des guests, exceptional guests internationaux. Je suis Giovanni Frisoni, je suis neurologue aux HUG et directeur du Centre de la mémoire. Et mon co-chair.
Bonjour à tous, Gilles Ali. Je dirige le Centenaire de la mémoire et on est très heureux de vous accueillir aujourd'hui pour un très beau programme, pour une pré-conférence qui s'annonce très prometteuse. Tu voulais présenter le modèle?
Oui, d'abord, le colloque sera en anglais. Le modèle est hybride, donc vous pourriez poser des questions en présentiel. Il y a des personnes qui sont à distance par Zoom qui pourront poser des questions dans leur par Zoom et les questions seront à la fin. L'idée c'est d'avoir un dialogue avec le professeur Dubois qui présente le diagnostic et le professeur Scheltens qui parlera du traitement. La discussion sera à la fin. Questions en présentiel et questions à distance. D'autres points, Gilles, que tu veux?
Non, je pense qu'on peut commencer.
Voilà, on peut commencer avec la présentation du premier speaker d'exception. Gilles.
So we switch in English. So it's a great pleasure and honor to present Professor Dubois. Professor Bruno Dubois is an emeritus professor of neurology at the Neurology Institute of La Pitié-Salpêtrière in Paris. He has led the INSERM research unit on cognition, neuroimaging, and brain diseases at the Brain and Spine Institute, as well as the Institute of Memory and Alzheimer Disease, IM2A, at La Salpêtrière Hospital. He contributes to more than 600 peer-reviewed publications, from apathy in Parkinson's disease to memory in Alzheimer disease, through bedside innovative clinical tests that you are every day using, such as the frontal assessment battery with Bernard Pilon, and the famous 5 mots de Dubois. Professor Dubois is a worldwide expert recognized for revolutionizing the concept of Alzheimer's disease by considering Alzheimer as both a clinical and a biological illness. Thus, it allows the development of biomarkers for identifying early stage of the disease. And more important, the development of treatments targeting molecular pathology. Giovanni, if you agree, I would like also to present Bruno. I would like to also present Bruno because as a resident, I had the privilege to learn what we call behavioral neurology alongside Bruno while performing my PhD. Working with Bruno was not just work. It was an experience filled with innovative ideas coming from the meticulous examination of patients coming from all over the France, such as this man who was brought to Bruno's attention because he was wasting his fortune while spending hours and hours with prostitutes. It was due to the beginning of a progressive supranuclear palsy. Or this former French minister with excruciating pain that was due to the first symptom of frontotemporal dementia. But more important, before his outpatient clinic, Bruno was inviting all his fellows to an Italian restaurant next door to La Salpêtrière Hospital to enjoy a good Italian meal with a very good French wine. Bruno is not only an excellent clinician and a curious and brilliant researcher, but he has the essence of a true mentor. Please welcome Professor Bruno DUBOIS.
these very kind words. Thank you very much. So, I will start by my disclosures, and I would like first to thank the organizer and Gilles and Giovanni for inviting me. But indeed, Giovanni and Gilles, I'm not sure that I will thank you for asking me to address the issue of what is Alzheimer's disease. Because, as you know, today, this is a very tricky problem, and I think it's a trap. It's a trap to try to answer this question today, because, as you know, there are at least two main orientations, and as a speaker, I am obliged to choose one of these. And this will be, of course, at the let's say, difficulty, because people in this audience will probably consider that the other one, that I will not defend, will be considered as the only good one to keep. So this is a real difficult thing to answer this question, what is Alzheimer's today? The second question is easier, because when you have defined what is Alzheimer, then it will be relatively easy to say how it can be diagnosed. So I will try to answer the question. And for that, I would like to start and to summarize all the ideas before the debate of today. Let's start by the beginning. And this is very important, because I think the key is here. At the beginning, Alzheimer disease was defined as a clinical pathological definition. On the one hand, you have well-defined phenotype with cognitive, behavioral, and psychiatric disorders on the one hand, and this was related to a well-defined neuropathological pattern with amyloid plaques and neurofibrillary tangles. So this was the initial definition of the disease. Since then, the definition became more clinical because of the difficulty to get information on the brain lesions in vivo. And then the diagnostic at that time was rather vague, based on the notion of dementia syndrome, and by exclusion of other causes of dementia, then we concluded to the diagnosis of Alzheimer. And the oldest in this audience, Philip and Stefano, probably remember that we used to say at that time it was probable Alzheimer's disease, indicating that indeed we could not ascertain the diagnosis. The new framework that we proposed with Philippe, Giovanni, and Stefano in 2007 introduced the biomarkers, and it was really a breakthrough because the biomarker can be considered as the surrogate of the neuropathological lesion. And thanks to that, it was possible to define now a new proposal, new concept, that Alzheimer's disease is a clinical biological entity consisting of a well-defined phenotype related to, here again, to the positivity of pathophysiological biomarkers. And more recently, as you know, there was a purely biological definition of the disease that was proposed by Jack in 2018, according to which the presence of amyloid positive and tau positive markers is sufficient to define Alzheimer's disease. And more recently, they propose an adapted version according to which the presence of amyloid positivity alone is sufficient to define Alzheimer's disease. So I think we are at the end of the process, and amyloid positivity is maybe or could be enough to define Alzheimer's disease. Is it true? Is it possible to define Alzheimer's disease on the basis of a positivity of an amyloid marker? The answer is no. No. It's not possible. It's not possible to define Alzheimer's disease on the basis of amyloid positivity. Longitudinal studies in cognitively normal subjects have shown that amyloid positivity cannot predict a further occurrence of symptoms. A majority of isolated amyloid positive subjects remain cognitively normal after even after several years or in their lifetime. And I just would like you to look at this proposal of Brook-Meyer showing that a cognitively normal adult of 60-year-old have only 30% of risk to develop a cognitive changes during his lifetime. That means that 70% of these cognitively normal subjects will not develop the disease if they are amyloid positive. And you have to know that this pattern is not significantly different from those who are amyloid negative. Based on this paper of Brook-Meyer, there is no significant difference between amyloid positive and amyloid negative in terms of risk to develop cognitive changes in their lifetime. And in addition, as you know, when you add the positivity of tau, tau positive markers, you increase marginally the risk of developing cognitive changes in the long term. So the question is, what is the definition of a biomarker? I think it's very essential. This is crucial for the definition of Alzheimer's disease. This raises this important question of the definition of biomarker. If a biomarker is a marker of disease, then, the inherent logic of the American Association new criteria should be that with the development of new biomarker, alpha-synuclein, TDP43, etc., in the future, we will be able to diagnose 2, 3, 4 neurodegenerative diseases in cognitively normal subjects. One individual will be diagnosed with 2, 3, 4 diseases that he or she will probably never express. And more interestingly, when we come back to what say the neuropathologists, who, as you know, look at brain lesion under the microscope, they clearly say that they identify lesions, but not a disease. In the ENIAC confirmed consensus in 2012, they concluded that Alzheimer's disease is a clinical pathological entity that should be disentangled from Alzheimer's pathology. So we propose with others in this room that biomarkers are markers of pathology, but not markers of disease. I think that's a very important point. With this in mind, we can now try to answer the second question that you asked me to address, how Alzheimer's disease will be diagnosed. To answer this question, I think we should respond according to the use case, and I will try to distinguish two different situations. First, the symptomatic, cognitively impaired patients on the one hand, and after we will address the issue of the asymptomatic, cognitively normal or unimpaired subject on the other hand. So let's start by the cognitively impaired people. I think this is very easy. This is very easy here because we have the symptoms and we will apply the clinical biological entity. They have well-defined symptoms that have been described, such as the amnestic syndrome of the hippocampal type that we have defined in 2004 and 2007, that we can identify based on specific memory tests that use the semantic queuing that you have with the free and two selective reminding test, or in clinical practice with the 5-word test. And as it has been shown by Wagner in 2012, the semantic queuing is the most efficacious to pick up those people that are the neuropathology of, or at least the pathophysiology of Alzheimer's disease. So in most of the case, it will be a well-defined amnestic syndrome. In other cases, it will be well-defined atypical syndrome that are characteristic of Alzheimer's disease, such as posterior cortical, logopenic variant, or frontal variant. So you have this pattern of well-defined syndrome on the one hand that will be related to the disease, to Alzheimer, based on the biomarkers, positivity of pathophysiological biomarkers, in the CSF, beta and tau positivity, or in PET with the PET amyloid positivity. So this is very easy today to define the Alzheimer in cognitively impaired people. Now, if we turn to the cognitively normal people, I would say that it is more complex. And I would like to define two different settings. The first setting is research. And I want to be very clear here in this room, for us, for those who are working on this proposal with me and Giovanni and others, we strongly support all research efforts to move towards decreasing the incidence of cognitive impairment in asymptomatic person at risk. No discussion. We totally endorse the view that clearing amyloid burden can prevent the onset of cognitive impairment. No discussion. And we totally agree that cognitively unimpaired biomarker positive subject should be included in research protocols, such as cohort studies for predictive algorithm, risk factors, preventive intervention, or clinical trials for secondary prevention protocols. So no problem with what is done on clinical research setting. This is totally different in the clinical setting, because as I told you just before, the risk of cognitive impairment in cognitively normal individuals with isolated amyloid positivity is only 17% over 6 years, and not different statistically different from a group of amyloid negative individuals. So there is an ethical dilemma, that is to disclose a disease that may never develop. However, and I think this is an important part of this talk, however, we agree that there are situations where the level of amyloid and tau PET aggregation is so high that the pathological process can be considered active and clinical symptoms are deemed virtually inevitable. And I will show you one example. That this is the example of amyloid positive and tau positive with a spreading out of the tau on the neocortical region. It has been shown that these specific cognitively normal people will develop the disease in 70% of the cases. So they are on the track to go to the clinical disease, as it has been shown in this paper by Simcoe. There are other situations that we can think about. For example, those who have a very high level of amyloid markers on PET with centroids above 68 who are in addition ApoE4 positive. Those who have a very strong burden of amyloid with a centroid over 77 and so on. So there are specific situation where these subjects who are cognitively normal, cognitively unimpaired, are on the track of the disease. So what we would like to do at the end of this talk is to define two different states in clinical practice. I'm focusing on the clinical setting. First, there is a state which is Alzheimer's disease, where we can define three different stages in the continuum. The dementia stage, okay? The prodromal stage, that is the part of the disease where you have symptoms not yet demented, but this is a symptomatic state. And third, a preclinical stage, which consists of subjects on the path of the clinical expression of the disease because of an autosomal dominant mutation or because of synergistic interaction between amyloidopathy and tauopathy. On the other hand, we consider that there is still a population of cognitively normal individuals with a biomarker positivity, who are only asymptomatic at risk because they have an undefined risk because of undetermined biomarker pattern, personal risk factors, and brain resilience that may interact and which render impossible to define the risk. And what we have to do is to work on this subject, because this subject should deserve our full interest. These people are interesting, and this is why we are working on this BH service, the brain health service, that is to determine the risk of this asymptomatic at risk. Because we have to work on the personalized Alzheimer risk profile. Some factors may increase the risk in this population. Of course, age and co-pathologies. Don't forget that co-pathologies play an important role in the clinical expression of cognitive impairment. On the other hand, you may have some factor that may decrease the risk of progression to Alzheimer's disease, such as protective genes or cognitive results. So I think that in the future, what we will have to do is to work in specific research setting and to identify those subjects who are cognitively normal, asymptomatic at risk, or even normal controls, and to include them in cohorts for a large database from which we will extract the algorithm of prediction, some real evaluation of the risk profile according to specific elements. And then on the brain health services that we are discussing and that we will discuss tomorrow with Giovanni and others, we will use these algorithms of prediction to answer the question of individual subjects that will come in our brain health service, asking for an evaluation of that personalized risk, okay? And applying this algorithm of prediction, we could probably propose some targeted intervention, either on modifiable risk factors that they may have, or disease modifier treatment in these brain health services. So this is the plan for the future. We have to do that. We have to work on that. We have to identify subjects at risk, include them in cohort database and algorithm prediction, and use this data in our clinic, in our modern clinic, which are these brain health services. So the take-home message, this is the last slide of my talk. They are very simple. First, the positivity of amyloid marker is not sufficient for the prediction of Alzheimer's disease in cognitively normal individuals. Second, in a clinical setting, Alzheimer's disease should remain mostly clinical biological. Third, in asymptomatic individuals, the diagnosis of Alzheimer should be limited to a small subset of biomarker positive individuals. And in the future, we have to progressively try to modify the group of asymptomatic at risk and take some of these to be in the preclinical stage, because they will probably benefit from the treatment that Philip will now present to you. Thank you for your attention.
Merci, Bruno. Questions at the end. So as you've seen, Bruno Dubois is not a shy person. He's jumped straight into the topic in the heart of what's hot in Alzheimer's disease, in the diagnosis of Alzheimer's disease today. Cos'è che continua a suonare? Now, it's my pleasure to introduce Philip Scheltens. Those of you who need me to introduce Philip Scheltens may be in the wrong room. You may have got into the wrong conference. But just in case, Scheltens scale should ring a bell to anyone. I first met Philip when he was already very famous. He was very young, but already very famous, because he developed a rating scale, a very easy scale to measure something that everyone was looking at, everyone was appreciating when consulting patients, but which no one had ever thought of giving a score to say, yes, it's atrophy, medial temporal atrophy is moderate, mild, severe, absent. And this is what he did. It was his first translational, well, first, maybe the most famous in any case, first and most famous effort to translate scientific knowledge into clinical practice. Because that scale, afterwards, he started to use it in his own patients. And we started to use it for our own patients. And after that, he has carried on with this translational effort, moving on to every other biomarker and for all earlier and earlier diagnosis, and then to treatment. And he finally built a memory clinic in Amsterdam that I don't know if you've ever visited it. It's the memory clinic which is basically the lighthouse of how patients should be treated ideally in a memory clinic. We've been, in the early days, when it was in Geneva, when I landed in Geneva, one of the first things I did was to ship my team to Amsterdam to have a look at how the Philips memory clinic was organized. Not because other memory clinics are not well organized. Amsterdam, it's different. It's different. What you may not know about Philip, and I will close, is that he's living a second life, the second of many, of course. He is now a partner at the Dementia Fund and chair of the Dementia Fund and partner of Equity Life Sciences, which is an investment fund. He is now scouting for promising treatments that deserve to be funded. So he has a privileged view on the most innovative treatments and those who are most promising and closer to fruition. And having said this, Philip, the floor is yours.
Thank you very much, Giovanni. It's very humbling to hear all this, and I know that it can only disappoint you now after hearing this. So it's true. I can advise everybody of you to start a second career after your first one. It's actually the advice of Mia to train your brain and to really sort of start all over again at 66 years of age. And I love it, I must say. And it's really challenging. And it has all to do with the treatment of dementia in general, not only Alzheimer's disease. But for now, for today, after hearing Bruno's wonderful lecture, and I almost agree on everything that he said, only a small detail that we probably can discuss, very small detail actually, the difference becomes smaller and smaller. So we'll discuss the treatment of Alzheimer's disease. Where are we now, today, in February 24? Because it's really very exciting times. So as you say, I'm full-time employed now by EQT Life Sciences. I have a team of 6 neuroscientists, and we scope and we scout biotech companies all over the world. And I'm also, one of the last things I do from my academic position, I'm a member of the Chain Committee of the EVOKE studies of Novo Nordisk, which is actually semaglutide in Alzheimer's disease, 2 very large studies. So if we focus on Alzheimer's disease and we use the pathology as defined by biomarkers, as Bruno so eloquently explained, we focus on amyloid and Alzheimer's disease because we think that is important. And I think that was also present in Bruno's talk. We see the history of these therapies, and it's a very long one. I don't think, sort of in 1906, Alois Alzheimer didn't try anti-amyloid therapies. He tried actually several therapies, nothing worked. But if you read the history, it's very excellent, interesting what he tried. But in all these years, we actually sort of got to know the amyloid hypothesis, the cascade in a way, and the link between A-beta and neurofibrillary tangle pathology, and how to diagnose this in vivo using the biomarkers, using the biomarkers for the pathology of Alzheimer's disease, which is quite correct. And then in 2021, the first accelerated approval of aducanumab, a monoclonal antibody against A-beta. And the second one, lecanemab, which is now fully approved, and now approved in the US, approved in Japan and in China. And in the second quarter of this year, we will hear what the EMA has to say about this. So it's actually a long history, and it's also, and you know this, it's a very costly sort of journey. This is a huge amount of costs, all borne mainly, I think, by the pharmaceutical industry over the years. And when I started the new job, everybody said, well, why would you invest in Alzheimer's disease? Because it's a nightmare, it's a graveyard, and why would you, everything fails. And that is indeed true until 2021, when we got the first approval, because we then showed that aducanumab really had an effect. But it's really costly. But if you put it into perspective, what is in oncology or in HIV or in any other sort of medicine part, it's also very expensive to develop drugs. So you have to put it in that perspective. So where are we? This is the amyloid targeting approaches that have been tried. And as you know a little bit about the cleavage of APP into the toxic peptide, which is called A-beta-42, by 2 enzymes, gamma secretase and the beta secretase. And then you have monomers, and then you have oligomers, you have protofibrils, you have fibrils, and ultimately you have the plaque. That's actually what Alois Alzheimer saw in his microscope. And in the gray boxes, you see all the different therapies that have been tried targeting these different sort of paths of the pathway to the plaque. Some of them failed, a lot of them failed, and some of them been successful. And I will, of course, now focus on the ones that have shown an effect. So we are making progress. So I mentioned aducanumab in June 21. Unfortunately, Biogen made so many mistakes just the path after that June 9 decision that they have now retracted the drug, and it's actually given back to the originals, which are in Switzerland, based in Zurich. You know, Christopher Hock and Roger Nietzsche, they discovered aducanumab in a very elegant and nice way with the reverse translation, looking at elderly people who had natural occurring antibodies against amyloid. They now have aducanumab back, and they're going to try to probably do something else with it. But Biogen has stopped it. But lecanemab has, as I said, approved, phase 2, phase 3, I will show you, and it's now approved. And donanemab is likely also to be approved in a couple of months. And gantenerumab, you may know as well, it's a Roche monoclonal antibody, one of the very first ones actually, that failed. And I'm going to show you that history again to show you how difficult it is to do meaningful drug discovery in Alzheimer's disease. So this is the gantenerumab story. I'm not sure whether you can see, but it started already in 2000 when they licensed in the antibody from MorphoSys. And then they started phase 1, phase 2, phase 3. Ultimately, phase 3 sort of had a negative results. They actually did a fertility analysis, and then they found out that the dose was too low. And then they started all over again with a 5 times as high dose as in the previous studies. They did another phase 2, another phase 3, and ultimately did 2 very big phase 3 studies, which is called the Graduate 1 and the Graduate 2. Interestingly, I was a part of that very first study in 2006, the phase 1, and you see the PET data over there. There was target engagement already, as shown by amyloid PET, in the doses intravenously, 60 milligram and 200 milligram at that time, showed an effect on amyloid lowering. So that was the confidence that they got in phase 1 to develop it further in phase 2 and phase 3, because there was target engagement. That was the very, very first time that somebody showed target engagement using a monoclonal antibody. But as you know, gantenerumab failed in the phase 3. And why did it fail? It didn't fail because it didn't work. It really lowered the amount of amyloid in the brain. It lowered the pathology, to quote Bruno. But it didn't do enough. And why that was the case? Because in this particular trials, which were MCI due to AD and early AD patients, so they had symptoms, they had impairment of daily living, they fulfilled the clinical criteria for Alzheimer's disease supported by biomarkers, but they had a very high amyloid load. 94.9 centiloids mean, which is very high. It's 100 is almost the maximum. So they had a brain full of amyloid. Then, in 24 months, actually, they reduced the amount of amyloid with almost 60 centiloids, so from 90 to 60, but that's just not enough. And that's why they didn't have, and now we know it's not enough because we have seen other trials, that's why they didn't have a clinical meaningful result. The figures are completely overlapping. So that's really a disappointment. But here is some news. One of the issues in monoclonal antibodies is that they do not cross the blood-brain barrier, or they do cross the blood-brain barrier, but to a very small amount, less than 1%. So that's why you have to give 10 milligrams per kilogram every other week or every month to get enough in the brain. So what if you have a system or a shuttle to actually open up the blood-brain barrier and get more of the antibody into the brain? And that's actually what they now have done. This was presented at CTAD just last year. It's gantenerumab. Together with a shuttle, we have the transferrin shuttle, which is on every cell in the brain, actually that actually can open up the blood-brain barrier. Then you enter the amount of monoclonal antibodies in the brain to a much higher degree. In fact, to such a degree, as you can see here, this is original gantenerumab. This is the ratio between CSF and plasma. So a measure of how much is actually in the brain. And you can see it's almost 4 to 6 times as high a dose with this shuttle. And what they also showed in this preliminary data set that they presented at CTAD, you can see now here, 12 weeks, 28 weeks, they already lowered the amount of amyloid with 62 centiloids to 84 centiloids, completely going to the 0 level of brain amyloid in a very short time. That is what happens if you increase the amount of sort of this monoclonal antibody in the brain. So very exciting work, and this you will hear more of. I think this is the path forward to, of course, to lower the dose and also have longer intervals of the dosing. But then, of course, we had lecanemab, phase 2, phase 3, stunning results. Actually, you can see big win on all outcomes for lecanemab in phase 3, as Alzheimer quoted at that time. So the interesting part is that lecanemab is a monoclonal antibody designed by a colleague of us, Lars Landveld, a Swedish neurologist who actually discovered the Arctic mutation, which is a mutation in APP that only happens in the northern part of Sweden, actually. And these people, they don't develop plaques, but they do develop an enormous amount of protofibrils. And he discovered that the disease, he described the disease, and he developed an antibody against these protofibrils. So, and that's where you can see here the A-beta protofibrils is the target of lecanemab. So, what is also a big lesson, and I've learned this also the hard way, and Biogen has learned this the hard way. If you do drug development and you want to go into phase 3, you have to know exactly what you're doing, and that's what you learn in phase 2. Phase 2 is where you learn the dose, you learn the effect, and then you can measure actually, and you can make a power calculation how many patients you have to do in phase 3. So this is actually what they did in phase 2. Very nice study, 18 months, as you can see, and they had different dosage. And they measured the dose, the adequate dose, on the amount of amyloid removal. As you can see here, PET SUVR is the amyloid measure that they used. And the lowest graph actually is the 10 milligram per kilogram biweekly, every 2 weeks. That was the higher dose coming from this phase 2 study, where they already had a CDR outcome, they had a positive clinical outcome, and a positive target engagement outcome. And then, if you do a proper phase 2, then you can almost expect that the phase 3 will also be positive. And that's what they showed. Here is again the amount of removal, but I point you to the fact that these individuals, MCI due to AD, early AD, with memory impairment and functional impairment, they started the study with biomarker-proven AD, but they started on a lower level of amyloid, 75, compared to gantenerumab, 94. 20 centiloids. That's actually, as was Bruno saying, if you have so much amyloid, you really have Alzheimer's disease. And if you have a little bit less, you are on the verge of this curve that you know very well of building up the amyloid. So if you start earlier, you're treating earlier, you have less amyloid, you can remove it quickly, and then you are to the level that the patients have no amyloid anymore visibly on the scan. So if you would do a scan, you would say, this is not Alzheimer's disease, or this is not Alzheimer pathology, because there is no amyloid visible anymore. So that's what happened actually in this study. So remove it for the large part. And then you can see this also in a sub-study that they did, 3 different tau levels that they also used in a sub-study of this phase 3 studies. And you can see if you start with a lower amount of amyloid, which is 40 centiloids, you absolutely, after already 3 months, you're below the level that you can detect it. And if you start very high, it takes much longer. So there's the evidence to start very early on treating, because then you have more time without amyloid to measure the effect. So this is what you see, the CDR sum of boxes, which is a clinical rating scale supervised by external people. Actually, it's an interview, it's a holistic interview, actually asking about the functions in daily life, your memory, etc., rated by the clinician. And this is what happens, 27% change, different from placebo and active. Now you can discuss, of course, and we can discuss this later on, is this meaningful or not? I don't know. Nobody knows, actually, probably, what is meaningful. This is the MCI ADL scale. I find this meaningful. This is activities of daily living, measured by a horrible scale. The ADCS, it's an American scale. I hope there are no Americans in the room. But it's really a horrible scale. But it does show an effect over time. And it does show an effect of the treatment as well. So, and that's actually more important, because that's function. That's actually what people report, that they do better or less worse than they did before. And this I found the most compelling, actually, because this is usually in an appendix, and people don't care a lot about these measures. These are health quality related measures. So the EQ5DL rated by the subject, or the quality of life rated by the subject, or the quality of life rated by the spouse, and the burden by the spouse as rated, caring for this patient who has every 2 weeks an infusion with a placebo or a monoclonal antibody, and they were all in favor of the treatment. That tells you that the patient himself and the spouse or the caregiver actually rated the response to the treatment, and you could detect it using these scales. So that's important. That's, in a way, sort of changing the quality of life. Now, they have tried to translate this. If you can think, well, what does it mean, these 27%? Well, you can, if you just prolong the curves, you can say, well, apparently the people who were on lecanemab had actually 7.5 months, they reached the stage later than the placebo group did at 18 months. So that's a way of translating this CDR score into something that you can discuss with your patient. Well, if I treat you with this, you gain months to the quality of your life, hopefully. What is important if you remove this sort of amyloid as a first pass? What happens downstream? And that you can measure with tau. Of course, CSF p-tau is an excellent measure of neurofibrillary tangles. And what they showed is actually, if you use placebo, you get a little increase, sort of amounting more tau pathology over time. And the active group actually had less tau pathology over time. You could also measure it in plasma, as you know. So this is also convincing in the sense, well, downstream something happens. And this is probably why people were actually had less symptoms on the CDR, because removing amyloid itself, as also Bruno said, I mean, nobody is actually sure whether this makes any difference for your cognition or function, but removing tau does. So then, of course, there are the side effects, and these are not negligible, and these are not trivial. This is ARIA, amyloid-related imaging abnormalities. We know these spots, we know this, we used to call it vasogenic edema. It's only seen on FLAIR images, so you have to do an MRI to spot it, because patients usually have no symptoms, a bit of headache, a bit of dizziness, perhaps. Only a few percent actually in the study had symptoms. So you had to do the MRI to make it. And then 12.6% of the patients had any form of ARIA. And the most prevalent risk factor for ARIA is ApoE4 carriership. And that is shown here in the next slide. And also the ARIA is happening very early on. In the first 3 months, the sort of 80% of all the ARIA events happen in the first 3 months. So the clinician really have to be very, very careful. You monitor the patient. Of course, you ask for symptoms, but you also make an MRI to be sure that the ARIA, it's not, I mean, it's not that you have to have no ARIA, because it's probably not even that bad to have ARIA. It's probably also a sign of efficacy, but you have to be careful that it doesn't really sort of increase over time. Usually it resolves within 4 months, and you can then start or increase the dose again. These are the risk factors of ARIA. This is mainly ApoE4, but also microhemorrhages that you can see on MRI. 0 versus any microhemorrhage actually also increases the risk of ARIA. Superficial siderosis, which you can also see on MRI only. Arterial blood pressure. The amount of amyloid is not a risk factor, so even high or low amyloid load doesn't really matter for ARIA. And antihypertensives seem to be a little bit protective for ARIA. So it's really, the message here is, it's not trivial, it's like chemotherapy, things happen, so you have to be careful, you have to really be prepared to monitor the patients very actively. Now also lecanemab, sort of, we know it's bi-weekly, 10 milligrams per kilogram infusion. It's very burdensome to the patient and very burdensome to the system as well. So of course they're working on different formulations, and this is actually also at CTAD presented a few months ago, subcutaneous formulation. So instead of an infusion, you do it yourself with the pen subcutaneously, and you can see actually that there is a very nice curve, the Cmax. With an infusion you get a lot of antibody and then it tapers down. With the subcutaneous formulation, you have over time, you have a more of a stable dosing. So we'll have to see how that plays out clinically. Now, of course, Lilly is also a monoclonal antibody against pyroglu A-beta, post-translationally modified A-beta. Very important, phase 2, phase 3, all positive. And they were reported in July last year in Amsterdam. And this is again the brain amyloid amount. You can see a dramatic sort of lowering of the brain amyloid in this particular study. And they had 2 groups. They had a medium, low, sort of a low to medium tau group and a high tau group. That's the sort of precision medicine that Bruno was also talking about, having the amount of tau. If you know the amount of tau, it actually gives you an impression of where the disease is and how far the disease is and what kind of symptoms you may expect. And also the progression is different. So if you can sort of precisely taper your intervention towards the amount of tau, that is probably very important. And that is shown in this particular trial as well. If you have low or medium levels of tau, you actually do better clinically. And also interestingly here on the right side, you see that 80% of the patients after the treatment were amyloid free. They had no amyloid on the scan anymore. And then you can say, well, perhaps we should stop the therapy and just wait and see. And then see how quickly the amyloid is building up again. And then make another PET scan and see how that goes. That's all for the future, but that will ultimately be determined by us clinicians, how to work with this. Again, CDR sum of boxes. In the low and medium tau population, 36% slowing, so a larger effect on the other one. And in the higher group, which included the high tau group, it's less of an effect, but still there is a positive effect over time. Here is again the p-tau changes, so the downstream changes again in the plasma p-tau in the high and the low group. And you can see here is an effect in both groups on tau. Now here, The most striking difference is in ARIA, actually, because donanemab is a much more aggressive monoclonal antibody and leads to higher ARIA incidences. So we saw the 12.6% of ARIA-E in the lecanemab, and it's double the amount in the donanemab study. And the symptomatics was 2.8% in lecanemab and roughly 6% in the other group. So be careful. Now, so this is a Lancet editorial, and you know the Lancet. It's a very sort of, I would say, carefully and also a bit I would say, almost old-fashioned journal. But they take a very, very important stance here. They say, well, time to get ready. Because what we know from medicine, oncology also, you have to genotype patients, or you have to have infusion centers, or radiation, etc. It's very, very, I would say, invasive. But the same thing will happen here. We have blood-based biomarker, imaging protocols, subcutaneous delivery if we don't want to do the infusion therapies over time. So health systems needs to get ready. That was the point that the Lancet editorial tried to make. Now, is this all? No. And is this the end? No. This is just the start. You have to start somewhere. But I think the confidence in the field is now there that we can actually measure. We have the right patients to start with. We can measure the target engagement, and we can measure an effect. But this is, of course, just a start. And I always use the comparison with multiple sclerosis. I mean, we started with beta interferon. Nobody uses beta interferon anymore. There are many, many other drugs that followed. And this will happen the same with the monoclonal antibodies. So there is a lot. There's the Wheel of Fortune of Jeff Cummings, phase 1, phase 2, phase 3. It's full. And there's a lot of activity here in the field of Alzheimer's disease modification, but also symptomatic treatments. This is one that you have to pay attention to. In 2 weeks' time, we will hear the results of Vivorion. This is a small molecule. This is an oral tablet that you can take. Also targeting pyroglu A-beta. Remember, the same target as donanemab. And this is an enzymatic approach because it targets the glutamate cyclase, which is actually important for sort of getting this extremely toxic pyroglu A-beta. And pyroglu A-beta is a form of A-beta that doesn't happen in normal aging. It only occurs in Alzheimer's disease because it's post-translationally modified. So that's where we are excitingly awaiting these results, because that will open up the avenue to small molecule drugs that you can take instead or add on to monoclonal therapies. This is also an interesting approach. This is targeting tau. This is antisense therapy, giving intrathecally, so with the lumbar puncture. And the antisense is targeting the RNA sequence to sort of give tau. And you can see here actually the effect of four injections with this antisense oligonucleotide at day 1, 29 to 57, 85. And then you can see over time, so this is in fact gene therapy, you can see the amount of lowering in the lower graphs here. You can see that the highest dose gave actually complete change in p-tau, a very sort of impressive lowering of p-tau, which is important if you think of the pathology of Alzheimer's disease. This is just phase 1. Phase 2 is now ongoing. And I will end with another one that's also this year. So 2024 is a really exciting year. A lot of things will happen. This is Alzheimer. That's a modified molecule that we know very well. Bruno and I think we are so old, we used to sort of did this clinical trial, tramiprosate it's called. It didn't work. It completely failed in phase 3. But later on in the post-hoc analysis, they discovered that it had an effect in APOE4 carriers only. And then they tweaked the drug a little bit. They called it ALZ-801. They did a phase 2 trial on biomarkers, impressive amount of lowering of p-tau. And this is the phase 3 trial ongoing and ending in May this year. And we'll hopefully have the results in July or perhaps a little bit later, comparing the ALZ-801, which is an oral, simple drug, once a day, against placebo over the times, and the ADAS is the primary endpoint. So there's a lot in the pipeline, and there's a lot to be wished for, and we hope that we will get as far as the multiple sclerosis field is now. So this is just to say that we are now looking differently to the field of Alzheimer's disease because we have these biomarkers, so we can define the patients, at least they have the pathology if you start, and then you can measure the effect, and you can also measure the amount of effect of the drug in itself. So, changing landscape. I must say. And it's interesting and for us very exciting to be in that landscape, because if you are as old as Bruno and myself, we started with nothing. We started with the NDN series criteria, as Bruno said, just making a diagnosis by exclusion, not knowing anything about what happens in the brain. Now we know, and now we have the first therapies as well. And I think in the end, we'll have combination therapies. We'll have to find out which combinations work best. Gene therapies, there's a lot that we will see in the future. Thank you very much.
Dear friends, I believe that you've not been disappointed by these outstanding visions of diagnosis and treatment. We really appreciated how diagnosis and treatment of Alzheimer's will be in the next few years. I see a number of young faces here, young physicians who will leave what Philip and Bruno have been describing in their daily practice in a few years. Now, I would like the speakers to come to the podium for the joint discussion. And I will leave my co-chair, please, Philip and Bruno, my co-chair to start with the first question from the audience online for hospitality. And then we will move on to your questions. Gilles?
Yes. So the first question is for you, Bruno. Okay. Is how do you define this asymptomatic patient at risk to develop? What is your cutoff? Should be defined on blood biomarker? Should be defined on CSF? Should be defined on PET? What is your suggestion?
I would say first we have to define asymptomatic. This is maybe a problem because after a certain age, people are complaining about memory. And for us, asymptomatic is people that have no objective deficit in cognitive evaluation. First, asymptomatic. And second, by symptomatic at risk, they may have a biomarker positivity, whatever the biomarker we are speaking about. Because, as I told you, what we have to define is the personal risk, personalized risk, and it is evident when you have both amyloid positive and tau, you are probably with a higher risk than when you have only, for example, tau or a beta alone. But so I would say that it's asymptomatic with any evidence of pathophysiological biomarker positivity.
Great. Any questions from the audience?
Questions from the audience. Does anyone? Okay, there's a number of them. Frank, Stefano, Richard, Frank. Okay.
So thank you very much for these two great presentations. A question for Bruno. Coming very similar to the question that just came up, you differentiated, which I think is very reasonable and very important, between amyloid positive, without evidence for tau, being more at risk, but then there is a subgroup of, I would say, amyloid positive and advanced tau positive, where we have recent studies showing that they are really at a very high risk, as you mentioned. So the way the studies were done was by tau PET, with a spread of tau beyond the medial temporal lobe. Now, tau PET is not really available on a larger scale. So do you see any other biomarker signature that could identify these individuals?
That's a good point. I don't have the answer today. We have to work on that, and the point is that we're advancing based on the published evidence. And what I've proposed is a published evidence. When you have the association of amyloid positivity and a certain type of tau positivity on PET tau, then you have a high risk of developing the disease in the next few years. So I think to answer your question, we have to do the job. We have to work on the predictive algorithm, including all the different patterns that we may have, and probably that, for example, as I showed, the level of amyloid may be enough in some cases. So we have to work on that, and to be, what we will do in our brain health service is to be the professional and says, okay, we will have such an experience in the next few years, seeing a lot of patients, lot of subjects with different patterns. We will be probably, as a cardiologist, that have a clear knowledge of the risk based on certain types of risk factors, certain pattern. So we have to learn this, and we are at the beginning of this new avenue, I would say.
Before taking the next question, I have a question. I will take advantage of this.
You can, but you can answer also the.
No, I want to ask.
Can I just add, or you want to?
No, I want to ask a question. We're all clinicians. We heard about effective treatments. Philip, the question is, how clinically meaningful are the diverging curves? This is the questions that everyone is asking us when we go presenting this. We have general practitioners here as well, not only specialists. Yeah. We have GP working with in primary practice. How clinically relevant is it?
I don't know.
Okay, next question.
I have a question for this.
So can I just answer like this? This question came up when we started using the cholinesterase inhibitors. We also questioned how relevant is this? A few points on the ADAS score. Who cares? Come on. So I thought that was actually a more relevant question at that time, because nobody could translate this ADAS score into a meaningful answer to the question to the patient. Yeah, is this meaningful or not? CDR is a clinical dementia rating. It encompasses a lot of things, not only memory. It's not a test. It's not a memory test. It's function, it's activities of daily living. It is a sort of combined score of how the patient is doing. And this is sort of, I think, it is a clinical instrument. So it gives you an information on how the patient does. And as I showed you, what the caregiver says about the patient informs me that these changes in curves, although the patient himself or herself will not notice that he's doing better or different, on the whole, the fact that you are slowing the disease is, if I would discuss it with the patient, can be meaningful.
But it's half a point over 18 months. Is that?
Well, I mean, you saw what you do if placebo, it is in all the studies that's why it's so interesting to compare these two, and then we'll have another one coming yet. You see that the effect is a class effect. So it's really an effect of those monoclonal antibodies. And I think we are now looking at a patient population who's relatively late in the disease, perhaps. If we start a little bit earlier, perhaps the effect is bigger. That's what the donanemab study showed. So yes, I mean, you can answer the question. You're a clinician. I mean, there is no other way than just pointing to the graphs and have a meaningful discussion with the patient. What do you think? What do you want? And adding a few months at the same period is probably also relevant.
About the clinical relevance, you were referring to the anticholinesterase inhibitors, but you have to know that even at the time, this was very, very a matter of discussion. And I want to remind you that in France, the ministry has decided not to reimburse this treatment because they consider that the clinical relevance was not enough. So I'm a little bit anxious about what will happen in Europe. Of this,
I mean, it's everybody who knows the answer can help us here. I don't have the definite answer. I'm not the one who decides what a meaningful outcome is. You can only show the data, and I think we as clinicians have to discuss the data as they are once we have these treatments and say, well, there's a risk, there may be a benefit over time, and this is a mean benefit. And what we don't know is how the individual patients actually did.
Okay, let me try and challenge you. Can we use? You've used multiple sclerosis as a comparator.
Yeah.
It makes a lot of sense to me. In multiple sclerosis, I understand this is what, I don't know that there's friends from, I don't see Patrice Lalive, for instance, but they tell me that disease modifiers delay disease progression by between 2.5 and 3 years. And it's considered acceptable, it's considered successful. Can we use that as a standard? If we use that as a standard of reference, most likely we will be able to delay disease progression of Alzheimer's disease, which is a 15-year long disease. We will probably be able to delay by 3 years. And multiple sclerosis, it takes much longer. So 3 years over a 25-year disease is less than 3 years over 15 years.
But the delay has to be meaningful in terms of where you start with. I mean, there is no use in delaying a disease progress which is already sort of having an impact on daily life. So that's another argument to start very early on. And then if you delay that process, and I think we should do the math. I mean, I find it always very interesting in multiple sclerosis, the EDDS, you know, that scales from 0 to 10. I mean, talking about rough scales, 10 is dead and 0 is nothing. And then we use CDR, we use all the scales. It's actually much more refined than what they did in MS. So I think we can do better.
There is one point that I want to discuss with you, because you didn't address this issue, and I think it's an important issue, because when we think about treating this patient earlier and earlier, as you said, and your point was well taken when you said, okay, when the level of A-beta of amyloidopathy is very low, it's probably here that we may have the higher chance to have a significant response. So I agree. The problem is that in this case, we are in front of cognitively normal subject. Let's think about the future. Cognitively normal subject at the very beginning of the disease, with no evidence that they will develop the disease. They have a very low A-beta level, and as you said, it's probably here that we may have the best chance to have a significant. The point is that these treatments are dangerous. And you didn't spoke to that so much. They are lethal. There is 4 or 5 deaths.
Yeah, you know why?
I just want to, and you have also severe side effects. And we had severe side effects. And it's very difficult to take care of this patient, of this cognitively normal subject in the future, when we will do that in cognitively normal subject. Because they are normal, and they may have a great and grave sequelae of a treatment that are not today, at least, totally free of any risk. So we have to take this in
Why do they have a...
Well, no treatment is without risks. And the deaths that you mentioned happened over 1,000 patients, only 4 deaths, but they were mainly caused, I must say, by the neurologists treating the patients in the wrong way. They were treated with antithrombotics because of a stroke or a TIA. And you know, if you have microbleeds and you start on an antithrombotic treatment, you get big bleedings. And that's exactly what happened. So
yes, I see. I agree that
all fake.
I agree that and others were also example of a bad management.
Bad management. And the ones that was recently published, already at the baseline scan, you saw this patient should never have been treated. So many microbleeds. Come on.
Yeah.
So it's a call that we as neurologists, we have to really sort of, I mean, we come from the time cholinesterase inhibitors you can just give and come back in 3 months. Here, this is a treatment that you can compare with the chemotherapy or multiple sclerosis that really sort of has also burdened on us as clinicians to do a really, really good job in order to safeguard the patients, of course.
But following Bruno's question and following your presentation of the risk of developing ARIA, should we adjust our inclusion criteria based on this risk to avoid ARIA? I was thinking mainly on the APOE4, actually.
Yes.
Should we keep patients
homozygotes.
APOE4 homozygotes.
Homozygotes. Yeah, I think homozygotes A4 have the biggest risk, and there are clinics also in the US that have already said we won't treat people with homozygotes, which is of course a pity because they have the highest risk. They also have more progression, but that's a decision because there you know that the risk is highest. And I would not exclude all E4 because that's 60% of the population that you end up with. And also the effect was actually bigger in the carriers than non-carriers. So it's a bit of a difficult issue. Yeah, but I agree.
To make a follow-up, so in the United States, we've been using anti-amyloid drugs for a while now. In the United States, we've been using anti-amyloid drugs for a while, from lecanemab, aducanumab. In the trials, we use specific doses, but now that they're in the
hands of a clinician that can make an individualized decision based on pharmacogenomics, ApoE44, I don't use 10 milligrams of either of these drugs. In an ApoE44 carrier, I've never gone above 7. I've cleared amyloid at 6 and 7. We've reduced amyloid at 3. So we have to make an individual decision. I think we have to be cautious about getting too worried about the side effects when you're not treating the individual patient and you're looking at aggregate data.
It's good. Thank you for that. I've spoken to a few colleagues in the US who are now gaining experience. It's early days. So in total, I think there are 2,000 patients in the US now treated in total. So that's not a lot. But I think that's wise. You have to start small and do it very organized. All the clinics are really sort of having teams that do this and very, very carefully discuss each and every patient because there is a danger. Yes. And if you can taper the dose, that's fine. That's great. I mean, nobody's just...
There was a question from Stefano Cappa. Then, Gilles, s'il y a des questions de la...
I actually have a comment on Bruno's talk. I agree with you as I usually do, but I think that this crucial point, so this sort of very clear distinction, which is not clear at all, in the definition of cognitive impairment, because you said, I call asymptomatic someone who has no objective deficit in performance. But as you well know, there are a lot of people who, I mean, this is not an absolute value because it depends a lot on which kind of tool you are using to define normal cognition. And I'm sitting close to Frank Jessen. So there is a very important side, which is the subjective complaint. So I think you agree on this. Among the conditions which may implicate a diagnosis of Alzheimer's disease in someone who's got a normal objective performance, there are some aspects such as this guy being possibly a super performer and complaining of decline, and or the fact that this guy has normal cognition standard testing, but if you use some special experimental tests, which are known to be sensitive but are specific, but this goes in combination with positive biomarkers, this might be another exception, or maybe some aspect of subjective cognitive complaint. I know you have ideas about this.
You know, you ask a question for which you know my answer. Of course, I think the problem is that we have to face people that knows exactly what is memory, what is attention disorder, what is complaint, what is objective deficit, and so on. So it's a problem of education, it's a problem of formation. I'm not speaking for you, because you know that better than me. But it's a problem of formation of doctors, because I think that there is a risk to consider that those who are complaining do have a memory deficit or memory problem, because you may have this kind of problem because you have depression. And if, for example, you have a tau positive in the blood, okay, we will consider that you have Alzheimer's disease and you have only an increased tau with a depression and some cognitive complaint. So that's a problem of formation. There's a problem of education. The difference between complaint and an objective deficit of memory in memory tests. So that's my answer. I don't know how we should do, but there is a problem. This is complex. Cognition is a complex work. It's a complex problem, and we have to educate those who are in charge of this approach.
More questions from the audience. Valentina.
Thank you. So
if there's questions from the younger ones,
that's
please
an educated audience.
Giovanni, I feel a younger one.
No, younger. Even younger, sorry, even younger.
Gentlemen.
So thank you. And a question for Philip. So we've talked about the idea of stratifying, of personalizing the subjects in order to treat. And some tools are there, blood biomarkers, imaging. We have some evidence on the different levels of tau that impact in donanemab, at least the amount of response. So if we go further for the next studies to be done, what would be your, let's say, your guess or your suggestion to the companies that come or to the new developers? Rather target with drug that target amyloid, rather include individuals that are amyloid positive but tau negative, with the idea of blocking the disease and let's say preventing eventually Alzheimer's disease as defined, or amyloid positive and tau positive, because those are the individuals that will decline most, a mix of the two?
Yeah, it's an excellent question. Of course, I could foresee this. I think, to me, prevention is the ultimate sort of goal, and we will talk tomorrow about the sort of ways of preventing, but also with preventing pathology. Amyloid and tau pathology is, I think, a challenge. I don't think monoclonal antibodies, in my opinion, would do that work. I mean, I think it's unbelievably sort of unbelievable to imagine that you would treat 4 years, 5 years in somebody who is only amyloid in order to prevent something. I don't think that's feasible. And it's actually not safe, probably also over such a long time. So we have to wait for the next generation of drugs that does this, small molecules and any other way, I think. But if I were to design now another amyloid treatment, I would first of all make sure that there is a lot more in the brain, as I showed with the shuttle, and there are many shuttles now on the way. So that's one thing. So a lower dose and more expression in the brain. And I think what is very important, what we have learned, is that you start with a certain amount of amyloid. The sooner you get rid of it, the longer you profit from it. So I would start with A beta positive individuals, amyloid PET positive individuals, and in the low to medium tau, because I do think you need symptoms, and I do think you need tau to treat a disease. And for prevention, I think we have to wait for better drugs in order to think about prevention. That would be my idea.
I agree.
Mia?
And now Mia comes, because I wouldn't mention the word prevention, and she immediately woke up.
Well, let's see what I will ask. First, thank you for wonderful talks, both of you. Really, so timely and interesting topics. First, Philip, question for you. You mentioned so nicely that this is just the starting and so much more is yet to come. And this nice figure, what kind of drugs are there in the AD pipeline? 28% of the new drugs are repurposed drugs. Yeah. And actually, I talked with Jeff last week, and he said that now the number is up to 40%. Yeah. So all of the new drugs tested for Alzheimer are repurposed drugs. Yeah. What's your view about that? Is there some hope for the repurposed drugs? They are easier to use. Can they be as effective? Yeah. Or is it maybe something for combination therapies?
Yeah, so I think you answered it partly. I think many of the repurposed drugs are in the symptomatic category, to be honest. And I haven't seen a lot of repurposed drugs that are working on disease modification, but there may be. And I think actually going back, maybe we have sort of seen drugs that failed because we didn't include the proper patients or we didn't include the proper endpoints. So it may be that that's also a way of repurposing, getting drugs back into the studies. So yes. The point is always with repurposing, of course, that sort of companies are not that interested to do it because there is less money to be made on it because the patent is gone, etc., etc. So you enter in a lot of problems. So usually it's academic studies. But yes, I think there is great hope. We are involved in Amsterdam in repurposing an HIV drug, actually, which in the in vitro models clears tau in the brain cells immediately. So it's a repurposed HIV drug at a lower dose, enters the brain. So that's an example.
Interesting. Yeah. Thanks. One question for Bruno, and thank you for highlighting this cognitively impaired, and if they have amyloid that is not so predictive. Okay, the question is how to even define cognitive impairment. It's not so easy. I'm thinking kind of risk score, like you saw, if you have amyloid and if you add things like your gender, age, comorbidities, and the value of biomarkers. We have seen this so clearly in the AD field when we start having blood-based biomarkers. How about the other pathologies? How close and how we could get there, having TDP, alpha-synuclein, vascular? Can we add that to the risk score in the future and have really prediction models to find those who are on the way down?
That's a very complex question. I don't have the answer.
I know.
I think that is exactly what we try to figure out with Giovanni and others. That is to to work on this and to have good. First of all, we have to be sure that our biomarker will be validated. That would be a first problem. And then we have to look at the conjunction of all these biomarkers to express a disease. But I think the co-pathology is also an argument which may go against a purely biological definition of the disease. Because, you may have some amyloidopathy in different situations. Doesn't mean, of course, that you will have an Alzheimer's disease, and the reverse is also the same. So, for example, everybody dementia and so on and so on. So, I agree with you that co-pathology would be a real problem to disentangle all these aspects in these aged people, because most of the cases, when we ask a question of Alzheimer's disease, it's generally over 70-year-old.
But probably biomarkers will, when we have, and they will come, there's already assays for TDP43 alpha-synuclein. When we have blood biomarkers for the major pathologies, it will be possible to estimate the risk, the attributable risk of each individual molecular pathology, as well as we have done in the past for adjusting education for occupation and in the very same way.
I agree.
So,
and you get a sort of mix and you get information. I think TDP43 is extremely relevant. It's very often co-pathology, but there are also diseases that are mainly driven by TDP43 that also have a little bit of amyloid. So amyloid removal is probably not that important, but TDP43 is important. So I think, yes, we'll get there. And that's why it's so interesting. So we have now this alpha-synuclein markers. And I'm not sure whether you saw the paper in Lancet Neurology 2 weeks ago of the Parkinson group, actually, now defining Parkinson's disease as a biological entity, synuclein neurodegeneration and genes, synergy they call it. And it's a very interesting concept. They follow the Alzheimer field.
yes, that's open. You mentioned a word, neurodegeneration, that may need a whole session to address. But
I just mentioned it, just as an example.
Yeah. Martin, and then after Martin, there was Umberto Nencia who had a question, and then Dorota.
Yes, it's around the answers here. I get it. We have to be very cautious with the safety of the ATTs. We need to learn much more. But what we have seen in the trials is that when you go into the earlier stages, the benefit risk is different. So if we learn more in the next years and we have the readouts of the preclinical AD trials, would you expect that if we have risk scoring in place, some patients who may not have comorbidities, maybe cleaner, younger, would benefit more? The benefit risk would be really in favor of using these drugs.
I think you're right. Yeah, but the point is indeed to get a grip on as many of the risk factors and predictive factors that we have in order to sort of have a good idea which patient is most likely to develop side effects and which are less likely to develop side effects. And regardless, you have to do a proper job, but I think that is very important. Because ApoE4 is just one, but there are probably many others that we don't know yet. And there are markers now being developed for CAA, for instance, because CAA can also be present without microhemorrhages, and it's a very significant risk factor for bleedings. So if we have good markers for CAA, that also may help. So it's all work in progress, but you learn by doing in a way.
Thanks. The microphone landed on. Okay, Umberto, you had the microphone. I didn't see that. You go ahead.
Thank you both for the amazing talk. I think I have a question more for Professor Scheltens. As you pointed out, one of the problems is blood-brain barrier crossing with these new medications. What is your take on the new technologies that may show some preliminary but promising results in helping this crossing, for example, focus ultrasound or other techniques of brain stimulation? Do you think they have a place?
A very nice paper in the New England Journal with aducanumab and this FUST. So this is focal ultrasound in MRI, actually. And by sort of giving this ultrasound, you open up the blood-brain barrier temporarily and more drug gets in. I think that's a very interesting experiment. It is, of course, adding to the complexity because you have to, at each different dosing, you have to go in the machine and you have to, I mean, it's already burdensome. So I think for experimental reasons, it's really interesting to see how this works. I think the future for FUS is actually more in gene therapy that you do intravenously and then open up the brain-brain barrier to get it where it should be. So I don't think for monoclonal antibodies. I think the shuttles that we have now, CD98 and transference shuttles, they work really, really very well. So I showed only one example, but many other companies have it. And that's much easier than FUS. But I agree, it's very, very interesting.
Dorota?
Merci beaucoup, Professor Dubois. But I have a question to Professor, to the other speaker. In European Academy of Geriatrics, we discuss a lot the current treatment, possibility of treatment, and we wrote a letter about that in like together thinking about some issues for older adults. But my question is about if you have the outcome with different cognitive scale for all these trials, for donanemab, do you have any other outcome? For example, mortality, survival, or clinically relevant for older adults like fall? Because people will be impaired with dementia when they fall down and when they have more infections. Then they develop confusion. So at the end of the day, it's not only the slow progression of dementia, but this big event that we see, especially with older adults, this, giants, what we say, falls, infections. Do you have any outcome in form of mortality or other outcome that are more clinically relevant?
I know that the mortality in the two trials that I mentioned was not different between placebo and active overall. So aside from the few cases that were documented, but the other endpoints, perhaps they were measured. I don't know. The only information I have is from the papers that you read, and perhaps it's somewhere hidden in the supplemental data. There is the false. I don't know, but I don't think it's there. And I agree. But you open up another question. I think that's for us as clinicians as well, and I'm curious what Giovanni will say, is will you think of, what kind of population are you thinking of treating? I mean, you said perhaps the younger population, but in fact, interestingly, in the lecanemab study, the younger population didn't actually do that well. It was the older population who had the biggest effect. So that is a bit counterintuitive. So I would also say, well, don't touch the 80-year-olds, but they'd actually do better on treatment than the 70-year-old. So we have to really learn more about all these therapies. And again, as the colleague over there said, I think we only will do this by doing it in practice.
We don't expect that older adults with frailty will be included in the trials. We have no this expectation even for other drugs,
of course.
So much. But later on, after the trials was 1 year and a half. Yeah. So later, maybe we'll see some in registry-based studies and so on.
I agree. That's why all the patients that are treated now in the US, they have to be in a registry. And that's very important. That will happen in Europe as well, because that's the only way we can learn about the long-term effect. Yeah.
There's one more
there is
question,
two more questions,
here,
one there and one there.
Another one over there, and then it will be $7:30.
First of all, thank you both for your amazing presentation. And my question is a bit about the future of our national health systems. So aducanumab and lecanemab have been approved in the US, which is critically different from most of the European systems. And I've read a few analyses about cost effectiveness of the drug, and there is some controversy even here. Yeah. So what's your take on the cost effectiveness of these new drugs, and should we really invest so much in these drugs or just wait for the next generation of drugs?
Well, it's a good question. I know in Sweden there have been some very critical, so Anders Wimo wrote a paper that the system would go bankrupt if we start treating. So I think the secret is here. So there are two factors here. There's the cost and the effectiveness. But there's also another, and that's the number of patients that you are treating. So I think what countries will do, and I know for sure the Netherlands will do as well, is to define a population to start with. I remember the early days cholinesterase inhibitors, our government was really afraid that 200,000 people should be treated. We can never pay it. in the end, we're only a few. So we have to start, and the US experience says the same, only 2,000 patients over the whole US, that's not a lot. So we start small. You define in each and every country a clinic or 2 or 3 or 4 who start, and then see how the experience will go. And then the other element in the equation is the costs. And I know that European countries are very good in negotiating costs. In the US, that has never happened because by law it was forbidden. So you couldn't sort of negotiate about the price. That's why all the pharma companies want to go to the US because the price is paid. In Europe, it's different. Italy has a different policy than the Netherlands. And we try to bargain as much as we can to get a lower price, and it will work.
We were born as traders in Europe, the Dutch, the Italians.
No, but it's also allowed here, and it's not allowed in the US. It was not allowed in the US.
Bruno, you have a comment on this point?
No, I totally agree. 2 points concerning the EMA. When and do you think that it will be a positive answer?
Yes, I don't know the EMA. I mean, I think it will be very hard pressed to think that they will not allow it. After China, Japan, China's even more. So they will do it. But the nice thing about the EMA is they can actually do a conditions, sort of formulate conditions.
And when we will have it?
The expectation is the second quarter of this year. So April.
Okay.
For those who are not aware, Philip Scheltens is also chairman of the World Dementia Council. So he has a privileged view on other
privileged view,
high-level decision making.
Yeah, but not in the EMA.
Well,
no, not at all. Still, I know they're working on it. So that's all.
Last question.
There was one question over there,
Yes.
and I guess that we will be done.
Better be a good one then. Then I had a question about the treatments, microRNA treatments that address the question of amyloid way before the accumulation of, since you can prevent the production of amyloid beta 40 and amyloid beta 42, then how do you think it will work? And since it would help with AD plus CAA, what do you both think of these kind of treatments?
You mean antisense treatments, or?
Yes. For example, I think there was an example, ALN, APP drugs that block the production of the APP gene.
Yeah. No, true. So there is actually, Alnylam is working on an APP blocking agent that almost knocks out APP production completely. And actually nobody in the room and nobody else knows how dangerous that is or how not dangerous that is, but they're working on that. And I think there are companies also working on gene therapy to sort of, in a way, change the production of A-beta 40 and 40 in the advantage of 38 and 39. So there are other ways to influence this amyloid process than just by blocking, by removing the plaques. Yeah.
So thank you very much. So it's time to thank our speaker. Thank you for coming and for staying. There is an aperitif right after. And I think
Before we go to the aperitif, bear with me just a minute. I have to thank a number of persons, and you have to thank them with me, please. Number one is the team that has organized this meeting. Mathilde Boyat, Olivia Antonietti, Christophe Moreau, and the team of the Centre de la Mémoire. I want to thank a couple of persons, authorities who are with us today. The past president of the European Academy of Neurology, Claudio Bassetti, and the president-elect of the European Academy of Neurology, Elena Moore. Thank you for being with us. Thank you to the sponsors. Thanks to the sponsors of this meeting. Without them, we wouldn't be here. Thank you very much. And last but not the least, the chairman of our department, who could not give the welcome speech, will give the farewell speech, so he will be remembered. For those with very short-term memory, he will be the only one who will be remembered tonight. Christophe.
Yes, you.
on a commencé en français, on va finir en français. À défaut d'avoir refait l'ouverture, je fais la fermeture. On a quand même pu voir aujourd'hui, grâce à Bruno Dubois, qu'on a fait beaucoup d'avancées, notamment au niveau du diagnostic chez les patients qui ont des problèmes mnésiques grâce aux biomarqueurs, et ça c'est une bonne chose. Il reste beaucoup de questions chez ceux qui n'ont pas de troubles de mémoire objectivés, et ça pose vraiment la question, comme on l'a vu aussi, de la sélection des patients pour les futures thérapies, comme l'a montré Philippe. Et merci beaucoup à ces superbes présentations, et beaucoup de questions pour la suite. Il n'en demeure pas moins qu'on rentre quand même dans une nouvelle ère, et c'est une ère qui est quand même très passionnante pour nous tous, et une ère qui va amener de nouveaux traitements pour nos patients, et puis de la prévention. Et c'est pour ça que je vous invite tous à venir demain au cycle de conférences qu'il y aura au Campus Biotech pour les Brain Health Services, qui va regrouper un petit peu tout ça. Et en attendant, je vous propose de nous retrouver autour d'un verre de l'amitié dehors. En tout cas, merci beaucoup pour être venu. Et puis,
merci Christophe, merci Gilles, merci Bruno, merci Gilles, merci tout le monde. Je le ferai à chaque fois.